Hello, good morning to all of you. Today I am taking class on prolonged labor. Today I will cover the topic on first I will tell you definition, causes, diagnosis, and the management will cover in the next class. So what is prolonged labor? The labor is said to be prolonged when the combined duration of the first and second stage is more than the arbitrary time limit of 18 hours. That first second stage is when patient is in labor. Okay. So first of all, what is normal labor? Normal labor is divided into 4 stages. Okay. In the first stage, there is onset of labor to full dilatation of the cervix, that is more than 10 centimeter. The second stage is from the full dilatation and the third stage is the delivery of the placenta. So the stages of labor is divided according in the normal labor. In the first stage, it is about 12 hours. The first stage completed from the new onset of the labor to the full dilatation. It's completed in 12 hours in primary and 6 hours in multi. Okay? And the second stage, that is the full dilatation to the delivery of the baby, that is in the descent of head and the delivery of baby. It takes 2 hours in primary and 30 minutes in multi. It is the maximum limit, normal limit, or the normal time duration we have to take. The third stage is 15 minutes in both primary and multi. That is expulsion of the placenta. If it is take more than that, then it is abnormal. Okay. And the fourth stage, it is the monitoring of the patient for 1 hour to look for any complication because of the normal delivery. Okay. So the stages of labor, it's a normal labor. As I have told you, the first stage, that is the stage of dilatation. It has 2 phases. First, the latent phase. So it starts from the labor last between 3 to 8 hours. It is shorter in multiparous women. And how we will say it is a latent phase? When there is a contractions, there is a true contractions, true labor pains occur in the patient. It leaves at least twice every 10 minutes, with each lasting more than 20 seconds. Then only you will say that patient is in the latent phase. Means when the cervix is 1 centimeter, 2 centimeter dilated and there are contractions. So patient is in the latent phase. What is active phase? Active phase meant from the 3 centimeter dilatation to 10 centimeter or more than 10 centimeter, fully cervix dilated. Okay. And her contractions are increases progressively and should be at least 3 times in every 10 minutes, lasting more than 40 seconds. In this active phase, the cervix will dilate 1 centimeter per hour in primary patient and 1.5 centimeter in a multipara. So it lasts between 2 to 6 hours. So the total duration of the first stage of labor in a primary patient range from 6 to 18 hours. So we will take it's at average account 12 hours, and it's a normal duration. Okay. So what is the second stage? It start. If any query, please send me on the chatting. Okay. If any doubt after the class. So in the second stage of labor, it starts from the full dilatation and end with expulsion of the fetus from the belt. It also has 2 phases. First is the propulsive phase. when there is full dilatation up to the descent of the presenting part to the pelvic floor. Expulsive phase is when the patient bear down effort and end to the delivery of the baby. So the average duration is 2 hours in primary and 1 hour in multi. Okay. So when we say it's a prolonged latent phase, latent phase is it's a preparatory phase of the uterus and the cervix before the actual onset of labor. So mean duration of latent phase is about 8 hours in primary and 4 hours in multi. And whether the prolonged latent phase has any adverse effect, it depends on the condition. Sometimes it's so much of prolonged and the neglection of the patient, it may cause meconium staining, okay, and dehydration to the patient. But usually it doesn't cause any endanger to the fetus and the mother. The latent phase, when exceed 20 hours in primary or 14 hours in multi, is abnormal. Okay. So, what are the causes which causes prolonged latent phase? It may be because of unripe cervix, malposition, malpresentation, cephalopelvic disproportion, or premature rupture of membrane. Hmm? So the malposition, malpresentation, CPD, what they cause, the cervix is not the cervix not properly riped, and premature rupture of membrane. The bag of membrane is ruptured, so there is no any um, uh, what to say. There is no not taken up. So the cervix is not taken up. There is no force from the abdominal part because the membrane is ruptured and the head is very high. In that case, the patient not go in labor. So prolonged latent phase may be worrisome for the patient, but it does not endanger the mother of fetus. Expectant management is usually done unless there is any indication for the fetus or the mother for expediting the delivery. Rest analgesics are usually given, and if needed, augmentation is done with the medical methods, preferably by oxytocin or prostaglandins like misoprostol. And amniotomy is avoided, and it's the second preferred. Only prolonged latent phase is not an indication for cesarean section. That is a prolonged latent phase. Now the prolonged active phase in first stage of labor. It may be the cause of three stages. It may be the power, hello, can you hear me? Okay, so what is prolonged first stage active? Okay, duration is more than 12 hours when the cervix dilatation is less than 1 centimeter per hour in primary and less than 1.5 centimeter in multi. The rate of descent is of the presenting part is less than 1 centimeter per hour and less than 2 centimeter per hour in multi. So failure of the dilatation, it's maybe because of three causes. First is a fault in the power. Power means uterine contractions. So maybe there is abnormal uterine contractions like uterine inertia or incoordinate uterine contractions, or there is fault in the passage like contracted pelvis, cervical dystocia, pelvic tumors, or even full bladder, sometimes not uh, uh, it's difficult for to onset of labor to progress the labor. So fault in passenger, that is the baby. The baby may be in malposition like occipitoposterior or malpresented like face bro, or there is any congenital anomaly like hydrocephalus. Two of have got sinister effect in causing non-dilatation also. So there is something abnormality in three levels, which may cause non-progress or prolonged labor in the first stage in the active phase. So prolonged labor in second stage of labor. It also in the divided into power passage and passenger causes. What is second stage? It is full dilatation to the delivery of the fetus. So mean duration of second stage is usually 50 minutes for nulliparous and 20 minutes for multi. But when we say it is prolonged, when it is, or when we diagnose it as prolonged, when the duration of in nulliparous is more than 2 hours and 1 hour in multiparous without any regional anesthesia. That is not, we are not giving any epidural anesthesia for painless labor. So 1 hour or more is usually permitted in both groups when we are using epidural anesthesia for painless labor. Hello, can you hear me? Variable degree of molding and caput formation in cephalic presentation. It is a part of the diagnosis of prolonged labor. Sluggish or non-descent of presenting part in second stages maybe, I have told you in three, that a passage, power or passenger. Okay. So there is fault in passage, usually that is the contracted pelvis. If there is a contracted pelvis, there is no descent of head. Abnormal pelvis like android and anthropoid. In this, occipital posterior position is more favorable. So in occipital posterior, the descent is late because of the internal rotation is in the long route. Like pelvic tumors, fibroid, and ovarian tumors, which uh, hamper the descent. Tumor of the rectum, bladder, or pelvic bones. Abnormality in the uterus and vagina, like scarring the cervix or the vaginal septums, rigid perineum. Fault in the power, that incoordinate uterine contraction, uterine inertia. Fault in the passenger, occipital posterior, malpresentation, big size baby, congenital malformation. So how will you diagnosed that there is a prolonged labor or there is something? So prolonged labor is not a diagnosis, but it is a manifestation of any abnormality in the three levels, that is power, passage, or passenger. The cause of which should be detected by thorough abdominal and vaginal examination and by pelvic assessment. During vaginal examination, if the finger is accommodated in between the cervix and the head during uterine contraction, pelvic adequacy can be reasonably established. So by assessment of pelvic inlet, any patient who come with complaint of pain in abdomen during preterm or term period, we have to first rule out that she is in labor or not. So there should be a contractions, which I have told you. There in 10 minutes, there should be 3 contractions of more than 40 seconds to diagnose as a case of true labor pain. If patient is in labor, then we have to see for the uh, we have to do pelvic assessment. We have to see the pelvis adequate for the baby size or not. Any there is cephalopelvic disproportion. For that we are doing pelvic inlet assessment. In it is covered in the normal labor. If it is the pelvis is adequate for the we will do monitoring for the normal progress of labor. For that we use Partograph. Latent phase is not covered in the new Partograph, and it is according to the WHO. In the WHO, the Partograph started in the active phase at 4 centimeter dilatation. Okay, so when the patient is in 4 centimeter, we start Partograph. As I told you, in the latent phase, before 3 centimeter or 3 centimeter, there is no need of any intervention we have to do. We just have to give analgesia to the patient for comfort and wait for the active phase. So patient will go in active phase. When the patient is in active phase, we monitor by doing 3 to 4 hourly vaginal examination for the progress of labor, and uh, and with that we monitor for the fetal heart rate with the contractions. If, as I told you, in the primary the dilatation is 1 centimeter per hour, and in the multi it is 1.5 centimeter. If the patient is going in the normal labor and 1 centimeter per hour in a primary, so you will see in this Partograph, according to that, in 1 hour, in there is actually in the Partograph there are two lines, the alert line and the action line. It is 4 hour difference between the alert line and the action line. So when it is 1 centimeter per hour dilatation, the dilatation and the line will go parallel to the alert line and right towards the alert line. So we don't have to do anything. We just have to monitor the patient and fetal heart rate and the contractions. If it goes towards, if the dilatation slow down, then the line will go towards the alert line. When the line goes towards the sorry, when the normal labor is, everything is okay, then it is in the left side. When there is any abnormality in the and the progress is slow, then it is in the right side of the alert line. So if it is on the alert line, we have to see for the cause. If it is a poor uterine contraction, we have to add uh, uterotonics for the progress of labor. When the progress is more slowed down and it goes in the more towards the right in the action line, we have to intervene accordingly. If it is not delivering, then we have to take for the cesarean section, or if she is fully dilated and the head is not descending, then we have to apply for the instrumented delivery. So in both in the action line in the right side, when it goes outside the action line, we have to intervene according to the operative procedure. So the active phase disorders are divided into two: protected phase and the arrest phase. In the protected phase, there is slowing down of the dilatation in the first stage. That is, cervix dilatation is less than 1.2 centimeter primary and less than 1.5 centimeter in multi. But patient is progressing, but the progress is slow. So it is a protected phase, inactive phase. It may be because of inadequate uterine contraction, CPD, malposition, malpresentation, epidural anesthesia. RS disorder, when there is no cervical dilation for more than 2 hours or no descent when active phase is commencing normally but stop or slows down significantly for 2 hours or more before full dilatation. Usually occur in CPD or malposition. Sometimes the contractions are very good, but there is the pelvis is not adequate. Even then the cervix will dilate, but the progress will be slow. That we have to assess when in the partogram, when the progress is slow and goes towards the uh, alert line. So we have to rule out when the line will go towards the right in the alert line, we have to reassess for the pelvic cavity to look for any CPD or contracted pelvis. So in second stage disorder, protection, it is divided also in the two phases. Protection and descent, that is descent is there but is less than 1 centimeter per hour in primary and less than 2 centimeter in multi. Arrest or descent when there is no descent. So when there is no descent, more chances of contracted or CPD is there or asynclitism. In case of malposition, usually there is a descent but it's slow. So what are the maternal complications because of prolonged labor? Patient may goes postpartum hemorrhage after the delivery, or there is a risk of operative delivery. We have to take the patient for operative delivery. So after delivery, even after operative delivery, there is risk of purpura sepsis or subinvolution. And the fetus have a complication like asphyxia, fetal distress, seizures, intrauterine demise or stillbirth, trauma, and sepsis. Okay, anybody have any query and you want to know anything more, then you chat me, then send me message, okay?